Today, I am Clinical Clerk Dave Marquez and I am going to demonstrate how to do an open tracheostomy. Tracheostomy refers to the creation of a communication between the trachea and the overlying skin. This may be done either by open or percutaneous technique, but this video demonstration will focus more on the open tracheostomy. Tracheostomy is indicated in conditions where there is a need for relief of airway obstruction, for respiratory support or assisted ventilation, for pulmonary hygiene, for elimination of dead space, treatment of obstructive sleep apnea, and to give way for head and neck surgery. For the relevant anatomy, the important anatomical landmarks that we need to remember in performing tracheostomy include first, the thyroid cartilage. The cartilage is composed of two halves which meet in the middle at a peak called the laryngeal prominence, also called the Adam's apple. In the midline above the prominence is the superior thyroid notch. A counterpart notch at the bottom of the cartilage is called the inferior thyroid notch. The thyroid notch is a palpable landmark to identify the superior aspect of the larynx in the midline. Next is the cricothyroid membrane, which is a palpable depression between the cricoid and thyroid cartilages as shown in the image. This is the location for an emergent cricothyrotomy. Next is the cricoid cartilage, which is a palpable landmark to identify the junction of the larynx and the trachea. The skin incision is typically placed 1 to 2 centimeters inferior to the cricoid. And lastly, the sternal notch, which is a palpable landmark to identify the thoracic inlet. It is important to palpate here to the possibility of a high-riding innominate artery that may be encountered during tracheostomy. During the tracheostomy procedure, the layers of the neck that may be traversed include first the skin, the subcutaneous tissue, the platysma in some cases, the investing layer of the deep cervical fascia, the strap muscles which includes the sternohyoid and the sternothyroid muscles, the pretracheal fascia, the thyroid gland in some cases, and the tracheal rings. It is also important to remember to be careful not to injure the anterior jugular veins, which are just superficial on the strap muscles. The trachea is a structure composed of incomplete cartilaginous rings except for the first ring, which is complete, beginning at the subglottic larynx and terminating at the carina and mainstem bronchi. The posterior wall of the trachea is shared with the anterior wall of the esophagus. The first ring which connects the trachea to the larynx is called the cricoid cartilage, as mentioned previously. Immediately lateral to the cervical trachea lie the recurrent laryngeal nerves and some peritracheal lymphofatty tissue. These structures are surrounded by the middle layer of the deep cervical fascia. Materials needed include the scalpel, the scissors, the retractors, the suction, syringe and needle, sutures, tracheostomy tubes, gauze, local anesthetic, and the tracheostomy tapes. Proper patient positioning. Place the patient in a supine position with the neck extended to provide adequate access to the cervical area. So you can place a pillow or a bag under the patient's shoulders to deliver the trachea out of the thorax. Now identify the surface landmarks. First, the thyroid cartilage, then the cricoid cartilage, and in between is the cricothyroid membrane or the depression between the two cartilages. Also palpate for the sternal notch, and 2 finger breadths from the sternal notch is the incision site, which is also equivalent to 1 finger breadth below the cricoid cartilage. Mark the incision site 2 finger breadths superior the sternal notch and the midline of the neck, which is also equivalent to 1 finger breadth inferior the cricoid cartilage. Now sterilize the area prior to the incision. Now anesthetize the site with 1% lidocaine. After a few minutes, check for the anesthesia effect. Make a horizontal incision on the previously marked site, then extend the incision through the skin and subcutaneous tissue. The horizontal incision is cosmetically preferable to a vertical midline incision. Now retract the tissues by Zahn retractors. So as I dissect towards the trachea, I will part the tissues with scissors, remaining strictly in the midline in a cervical plane to avoid injury to the inferior thyroid veins. This can be done by intermittently palpating the area. Then identify the midline cervical fascial plane between the sternohyoid muscles and divide this intermuscular plane by spreading with a pair of scissors. Repeat this maneuver to separate the sternothyroid muscles and retract the muscles laterally. Now we can see the thyroid isthmus overlying the second and third tracheal rings. So we now retract the isthmus superiorly to expose the trachea. Now expose the infrathyroid trachea by carefully parting the overlying soft tissues with a pair of scissors, taking care not to tear the inferior thyroid veins. This is visualized by the blue string as seen in the setup. Now ensure that the surgical field is completely dry before proceeding, as it is difficult to achieve hemostasis once the tracheostomy tube has been inserted. Once the tracheal area has been visualized, communicate with the anesthesiologist to ensure safe FiO2 levels. You may now make an incision on the trachea. The safest tracheostomy in adults is to create an inferiorly based flap raised from the anterior wall of the third and fourth tracheal rings. This is called the Bjork flap, which is an inferiorly based flap to prevent the false passage of the dislodged tube when we are replacing it. Now a silk traction suture is passed through this anterior tracheal flap and loosely secured to the skin. The traction on the suture facilitates reinsertion of the tracheostomy tube in case of accidental decannulation. Now communicate with the anesthesiologist to deflate the cuff of the endotracheal tube and gently pull it back until the tip is just above the opening. Now I will gently advance an appropriately sized tracheostomy tube through the opening in the airway. Once the tracheostomy tube has been advanced, inflate the cuff, remove the obturator, then insert the cannula and connect it to the ventilatory circuit. Now head ventilate while correct placement of the tube within the trachea by confirmation of the expired PCO2 levels of the patient and checking for chest movement or listening to breath sounds. I will now secure the tracheostomy tube by suturing it around the skin but not too tight to avoid surgical emphysema. Now thread the tapes through the holes in the flanges of the tracheostomy tube and pass them around the neck. Tie them with the neck flexed. For intraoperative complications, this includes bleeding, which is the most common, airway fire, which is rare but is very disastrous and occurs due to the complications of high oxygen concentration in the anesthetic tubing, and pneumothorax or pneumomediastinum because of the inadvertent creation of a false passage. For early post-operative complications, it includes infection, which occurs very rarely and doesn't really require antibiotics and is usually managed using local wound care. Next is the acute obstruction of the tube, which can be caused by blood or mucus, which can be avoided by scheduled tracheal suctioning, humidified oxygen, and scheduled cleaning of the inner cannula. We also have late post-operative complications, which include pressure necrosis, stenosis, and formation of fistulas. Now that ends this demonstration video of open tracheostomy. Thank you for watching.